79-year-old man comes to office with shortness of breath, with exertion and productive cough. He has medical history of heavy smoking for 25 years. Vital signs are normal except respiratory rate. On physical examination, there is increased resonance to percussion, decreased breath sound, and crackles at lung base. Chest radiography shows pulmonary hyperinflation. Spirometry shows FEV1 is decreased, FVC is kind of normal, FEV1 to FVC is decreased. Which of the following is most likely diagnosis? Asthma, lymphangioliomyomatosis, COPD, bronchiectasis, heart failure. Okay. So this one said that, so basically in this question, what was going on is that this patient is having a history of shortness of breath and productive cough for some time now, and he has history of smoking. Um, on spirometry, all the symptoms that were present kind of pointed towards an obstructive lung disease. And on X-ray, there were symptoms of hyperinflation. So they are asking which of the following is diagnosis. So as you guys answered, it is COPD. So let us see. Okay, so basically, it's if it's COPD, as you guys have pointed out, and all the features present here in the spirometry points towards obstructive disease. Why is it not asthma? So basically, what I'm trying to ask you um, is the feature that we have here point towards obstructive disease? Okay, obstructive disease include both COPD and asthma. Both COPD and asthma are given in the option. So why are we choosing COPD and not asthma as the answer? What? Yeah. So basically, this patient is having a prolonged history of smoking. In that case, usually the option the question is pointing towards COPD whenever there is a heavy smoking history. Many times it's very difficult to distinguish between COPD and chronic asthma. However, in this case, the history of smoking kind of gives away the answer as COPD. So let's quickly go through a few important points for this question. So basically, yeah. So what you should know is all this. I'll explain. Yeah. Okay. So in obstructive lung diseases, FEV1 decreases. In restrictive lung diseases, FVC decreases. So basically, I myself remembered only this much. For obstructive lung diseases, FEV1 decreases. And for restrictive lung diseases, FVC decreases. I just remembered this, and rest everything was like easy to figure out. So if FEV1 is decreased, in that case, this ratio is going to decrease, and FEV1 to FVC ratio is going to decrease. So in obstructive lung disease, FEV1 decreases and automatically FEV1 to FVC ratio decreases. In restrictive lung disease, FVC decreases. This is what I remember. And since denominator is decreasing, FEV1 to FVC ratio is normal or increased. So this is what I remember. And this is going to kind of come up in some or other question in the exam. And you should be able to figure out difference between obstructive and restrictive lung diseases. Let me check. Okay. Okay. So there is this another chart for you to see for, yeah. I know that this is not very clear, but let's go with whatever we have. So in spirometry, if there is low FEV1 to FVC, it's obstructive lung disease. If there is normal to high FEV1 to FVC, it's restrictive lung disease. How do you distinguish between asthma and COPD? You do a bronchodilator challenge. Basically, you give a bronchodilator. If there is increase in FEV1, basically if the obstruction improves, it's asthma. If there is no change in that obstruction, it's COPD. Now, in restrictive diseases, how do you distinguish between um, chest wall diseases and interstitial lung diseases? So you mentioned DLCO, diffusing capacity of lung by measuring the diffusion capacity of carbon monoxide. You measure that. If it's normal, it's chest wall disease. If it's abnormal, that is, if it's decreased, it's interstitial lung disease. We'll come again to this figure for next question, I guess. But I hope that it is clear how to distinguish between asthma and COPD when it's not clear, when it's not very precisely given in the question. So first of all, you should try to look into the history. If the history suggests there is a lot of smoking, if there is no previous history of asthmatic attack or family history or any history of eczema or allergy, we are looking towards COPD. If it is given in spirometry that giving bronchodilator improves the obstruction, it is going to be asthma. So I hope that this question is clear so that we can go ahead. Just write a yes in the chat box and then we will move ahead. Yeah. There's this one question that says, can you say some points about DLCO? We will go through this in the upcoming question. There will be more detailed description about DLCO. Then there is this one more question which says, what if irreversible asthma? So that was what I told in the beginning of the question. It is very difficult to distinguish between COPD and chronic asthma on spirometry. So I think this is given in this response as well. If you can read over here, where is this asthma? Where is that? Check. Yeah. So they have written spirometry before and after bronchodilator is indicated in initial work of patients suspected with having asthma. So that is how you usually distinguish. But in some patient with chronic asthma, a clear distinction from COPD is not possible. In that case, what you see is the history, as I told. If someone is having chronic irreversible asthma, it is most likely chronic asthma. So he or she should have some kind of complaint of uh, like, let's say, eczema or history of asthma or something like that. So there should be some history, and this patient did not have such history. So in that case, you can see whether it's asthma or not. So basically, to answer your question, if it's irreversible asthma, it is difficult to distinguish in spirometry, and you will look into history.
Thanks for watching. Please give a thumbs up and subscribe for more.